Now, it turns out that the white matter disease actually, there's a variety of different genes, more being described every day in very small numbers of patients where white matter is also part of this, okay? For example, carousel was the next one. This one is an autosomal recessive, so the manifestation is quite rare. It happens at a younger age. Clue here is alopecia, low back pain, and arthropathy at a young age. But we're learning more and more about these. And we're also finding out that in addition to Notch mutations and other mutations, that collagen disease is also important in looking at this. So now let's switch gears a little bit and talk about an X-linked disorder. So this is a disorder where the female carries a mutation on one of her X chromosomes. When she passes that along to her sons become symptomatic. She also passes it along to her daughters. Now, classically, we're told that women who have two X chromosomes are going to be asymptomatic in an X-linked disorder. In fact, in this disorder, like many X-linked disorders, although the women may be less affected, they still may be symptomatic, and they may still develop either milder at a later time in life some of the manifestations. So this disease is an enzyme defect. So it results in the absence of an enzyme that's able to chew up or degrade lipids. And so you get deposition of sphingolipids throughout multiple parts of the body. Now, classically, as neurologists, we're taught about this disease as being something that happens in young children, where they complain of painful burning extremities or sharp pains in the extremities. They develop early cataracts, disorders of sweating, and skin changes called angiokeratomas. And here we can see, here's the deposition of this sphingolipid on an electron micrograph. This is actually, I believe, a skin biopsy. It's actually deposited in many, many tissues, and that's why it causes disease in many, many parts of the body, but the neurological part oftentimes can be quite devastating. When these sphingolipids are being deposited, you can actually see some changes in facial features. So here are two affected brothers with an unaffected sister, and you can see kind of the coarsening of the facial features because of deposition of this lipid in the skin, and this may be progressive over time. Now, although we think of this as being a childhood disease, there are some patients who don't have any of the childhood syndromes, but they present later in life. There are a group of patients who present with cardiac disease. Renal failure is a major problem for young patients who present with it, as well as occurring sporadically in older patients, and stroke. Although this is a rare disease, there's a thought that in some enriched populations, it may be relatively frequent. For example, if you go to a dialysis center and you look at patients who have no known cause for their renal failure, okay? They don't have degenerative disease, they didn't have an inflammatory nephropathy, they didn't have long-standing juvenile onset diabetes, no reason why they really had a kidney disease, right? About 5% of those patients are going to be positive for Anderson's Fabry's disease, okay? Relatively high number for a rare genetic disorder, which on average is 1 in 40,000 to 1 in 120,000 people. The reason we think about it is, and it provides kind of an interesting light of some of the challenges we're going to have in treating these rare disorders, is that it is treatable, or perhaps a better way of saying it is preventable. So in the United States, there's one approved product for reducing the deposition of the sphingolipid in kidneys and other cells. It's called Fabrazyme. It's given as a once every 2 week infusion, IV, okay? It costs $200,000 a year to get it, okay? So it's incredibly, incredibly expensive. And if you want to hear some interesting things that happen when a drug is that expensive, you can type in Fabrazyme and see some of the issues that have come up in the initial scientists who put it together, and the company that then was put, and what happened to that company as it became a for-profit company, kind of an interesting and maybe cautionary tale. From the stroke standpoint, what I want to say here is that once you have an established phenotype of blood vessel disease in stroke, it has not been proven to reduce the recurrence of stroke. So it's actually more important to recognize this disorder because perhaps you're going to be offering it to other family members who have the disease and try to prevent stroke and other diseases, especially kidney failure, in the future for those patients. Now, the typical skin change that we see in these patients is excessive amounts of angiokeratoma corporis. Diffusum means extra amounts. It's kind of an erythematous papule. These are typically located on the trunk and the lower proximal lower extremities, kind of what's called the bathing suit distribution. Now, the key here is the babies don't come out with this, okay? This is something that gets worse as the years go by, okay? And this is not pathognomonic for this disease. This can occur in other conditions. But excessive amounts of these, again, sometimes patients come in and say, isn't this odd? I've got all these little red dots, would be something that might, anytime you're thinking odd, we'll get back to that theme. What kind of strokes are associated with Fabry's disease? Well, it can be both bleeding and non-bleeding strokes. It does cause small vessel white matter changes, but on imaging, you'll often see asymptomatic arterial dolichoectasia, huge, dilated, tortuous blood vessels, particularly in the posterior circulation. And another sign, which is very suggestive of this, on imaging is the so-called pulvinar sign. There's another pulvinar sign that's in sporadic CJD, but this is the deposition of calcium in the pulvinar. These are 3 separate patients with early, moderate, and advanced disease. You can see this deposition of calcium and a CAT scan. This shows up as hyperintensity on T1, and on a heme-weighted sequence like T2 star, you can see these dark intensities here. If you see this is very concerning, and you might want to mention or think about Fabry's disease as something to think about. Okay, so 2 down and a few more to go. How about something that probably we've all heard about, and we probably may even already be thinking about and recognizing? Marfan syndrome, okay? So these are patients who are tall and long. They have long fingers and long hands. They may have associated skeletal abnormalities. They may have dislocations of lenses, early cataracts. And more importantly, in terms of their health and the health of their family members, is they can have vascular fragility. So they develop aortic aneurysms which just suddenly rupture, okay? And this can be fatal. If you know about this ahead of time and take care of this ahead of time, you can significantly decrease people's morbidity and mortality. So even though there's not a cure for Marfan's disease, making this diagnosis or even just thinking about whether a patient has this kind of a connective tissue disorder can have implications for the family. It's relatively common, 1 in 5,000 worldwide. It isn't autosomal dominant. The gene that's involved is the gene coding for a protein called fibrillin-1. It's an extracellular matrix protein. Interestingly enough, we think that this interacts because it is no longer effective in decreasing tissue growth factor beta. And this will become a recurrent theme and maybe something we'll hear about more in the future as some of these genetic disorders seem to be coalescing on this tissue growth factor beta pathway. We said about 25% of these are de novo mutations. And again, changes within this gene can cause other familial syndromes that don't normally have strokes. Now, when we said that these patients have abnormal tortuous vessels, this is what we're talking about. All of us, our vessels get a little bit tortuous as we get older. Here's a person whose internal carotid artery takes like 4 loops before heading up to the brain. And this is an area where the vessel wall is weakened because of cystic medial necrosis and gets these very characteristic things, put the patient at risk for arterial dissections. Ehlers-Danlos syndrome, this is again something where we had a variety of syndromes that have been named throughout the years. We thought genetics might make it a lot easier by pointing out exactly what the mutations were behind these. It has simplified it somewhat, but we still have many genes that are causing each one of these disorders. The vascular or ecchymotic type is the type that's really associated with increased risk of stroke, whereas the hyperextensible joints and Marfanoid patients really generally don't have an increased incidence of stroke as much. The type 4 disease are only mutations in the COL3A gene, which codes for type 3 procollagen. Not 100% sure how mutations in this cause the disease, in fact. 50% inherited, 50% de novo. There's a variety of different photos of what these patients look like. Important thing is that these patients almost all develop life-threatening complications of aortic rupture, organ rupture, spontaneous colonic perforation, uterine rupture, before the age of 40. So asking people not only what diseases run in the family, but what age people had them at. Okay, my first patient, who had a connective tissue disorder, basically said, "Tell me about your history." I had a hernia operated when I was 12. I said, "Hernia when you're 12? Don't you think that's a little unusual?" She said, "Oh no, my dad and his brother had hernia operations when they were 13 years old." Okay, to her that just seemed normal. To me, that seemed like genetic disease. So asking about this is important. Now, interestingly enough, these patients, although they're part of Ehlers-Danlos syndrome, and some patients and some types of Ehlers-Danlos are marfanoid in appearance, these patients are not. They're generally of small stature, slight build. They have very thin, translucent skin, and sometimes patients will even comment at how you can see prominent, blue veins as they're stretching their skin. They, as I said, asking for family history of premature death, and it is important in these patients. They have a kind of a typical facial appearance called acrogeria, which the face looks emaciated and thin with sunken eyelids and rather prominent temporal wasting. Again, someone who you'd look at and say, this person looks, a little bit different than I would expect someone their age to look like. Okay, so now I'd like to talk about one of the diseases that I actually am seeing patients with, and perhaps overall, not just MELAS, but all mitochondrial-related diseases are actually probably some of the most common mutations that we see, but we don't recognize them when they see them. So MELAS, ragged red fibers, myopathy, MRF, gastroenteropathy associated with mitochondrial disease, progressive external ophthalmoplegia. These are disorders that people see as separate things, but they're all mutations of mitochondria, and taken together, they're actually quite common. The mean age of presentation with MELAS is quite young. Presentation at age 10 years old, some patients as young as age 2. They can have stroke-like episodes, which can look a lot like strokes, with a sudden presentation of hemiparesis or aphasia, or particularly visual loss is a common symptom. They'll often present with seizures in accompanying with the stroke-like episodes. Okay. Interestingly enough, they can have a lot of other premorbid syndromes, headache, cyclical vomiting, hearing loss. Okay, is a big one. And interestingly enough, a key here often is that they have an episodic encephalopathy. So they're a stroke patient, but they look more confused than you would expect, and the lactic acid is high. Some of these patients actually have previous admissions for culture-negative sepsis. Okay? They come in confused, brain edema, some focal stroke-like symptoms, and high lactic acid. All the blood cultures are negative. They get better after they're treated for a little while. They carry that diagnosis, but it's actually MELAS. In addition to those things which are part of it, you can also see, even within MELAS, overlap symptoms with eye findings. Diabetes is another one. So we said, absence of vascular risk factors or presence of vascular risk factors doesn't rule out genetic disease, because we expect people with MELAS to end up having diabetes. They're often of short stature. And not everybody has all these manifestations, so you can have a lot of variability in the family. Of the families I've taken care of, only one family had a prior member diagnosed with MELAS. All the other ones, although they had other family members who probably manifested the disease, they're unaware of the syndrome. So what about MELAS presenting as an adult? Okay, not with the typical symptoms, but as stroke-like symptoms in an adult. What do their stroke-like symptoms are? Well, it is a cause of stroke in the young, but the oldest reported case is 63, where they made a new diagnosis of MELAS. Okay, we said there can be a predilection for occipital lobes with blindness or hemianopsia, but doesn't have to be. We said that EEG changes and frank seizures, even status epilepticus, partial continuous status is quite common. The imaging actually can look a lot like regular traditional strokes. So here's an example of a patient who comes on with a homonymous hemianopsia, right? This is a typical vascular territory. This looks like a diffusion positive low ADC stroke. Now, this patient, however, makes a great recovery. All their stroke symptoms go away. And surprise, surprise, 2 months later, now they come back, they've got a stroke on the other side. You say, okay, after a thrombotic disease, that happens, one stroke, many strokes. But look what happened to the other side. There should be a big hole of encephalomalacia left there from the prior stroke, which damaged tissue. It's disappeared, okay? And so one of my first MELAS patients, she came in with what looked like a complete stroke, complete paralysis, complete sensory loss, complete vision loss, went to rehab. In 3 weeks, she was home, modified Rankin score of 1. And her primary care doctor said, you had a stroke, but boy, this is a little bit unusual. And after 5 months, we can see, again, this one, there is some signal change here, but again, this one has disappeared. So this kind of disappearing strokes are actually part of the clues, perhaps, for MELAS.